Namaskar. Welcome in this live interactive teleconference of screening of breast cancer and cervical cancer. Dear friends, as you know that as a nation, today we are celebrating स्वस्थ नारी सशक्त परिवार अभियान, क्योंकि एक स्वस्थ नारी ही एक सशक्त परिवार एम्पावर्ड फैमिली बिल्डअप कर सकते हैं। और परिवार में वुमेन का हेल्थ बहुत इम्पोर्टेंट है। और उनमें से अगर आज के दिन में देखा जाए तो हमारे देश में बहुत सारे लोग, मतलब बहुत सारा जो परिवार के नारी है वो ब्रेस्ट कैंसर से या फिर सर्वाइकल कैंसर से पीड़ित होते हैं, जिससे परिवार में बहुत मुश्किलें बढ़ जाते हैं। तो हमें स्क्रीनिंग करने से क्या होता है कि बहुत फ़ायदा होता है। अर्ली स्टेज ऑफ डिजीज़ हम डिटेक्ट करके हम उस बीमारी का प्रॉपर इलाज करके हम परिवार को कैंसर मुक्त बना सकते हैं। तो यह सब डिस्कस करने के लिए आज हमारे साथ है डॉक्टर अमिता नाइथानी। वेलकम यू डॉक्टर अमिता। डॉक्टर अमिता एक सीनियर कंसल्टेंट है आर्टेमिस हॉस्पिटल गुड़गांव में। डॉक्टर अमिता HOD है हमारे गायनी ऑन्कोलॉजी डिपार्टमेंट की। तो थैंक यू वेरी मच डॉक्टर अमिता टेकिंग आउट योर टाइम। सो प्लीज़ आप हमें ये बताइए कि हमें ये स्क्रीनिंग की ज़रूरत क्या है ब्रेस्ट कैंसर और हमारा सर्वाइकल कैंसर के बारे में।
शुभ संध्या, नमस्कार। मैं डॉक्टर अमिता नैथानी, मैं गायनी कैंसर स्पेशलिस्ट हूँ। पिछले 15-20 साल से मैं सिर्फ गायनी कैंसर ही ट्रीट कर रही हूँ। ये बहुत एक अच्छा मौका हमने आज चुना है प्रधानमंत्री जी की योजना के तहत और नवरात्रियों के तहत कि हम ये आज योजना कर रहे हैं कि हम कैसे नारियों को, जो हमारे देश में सबसे महत्वपूर्ण कैंसर से पीड़ित हैं, सर्वाइकल कैंसर और ब्रेस्ट कैंसर से, हम कैसे स्क्रीनिंग करके उनको जल्द ही बीमारी को अर्ली स्टेज में पकड़ के हम कैसे उनकी सहायता कर सकते हैं कि वे एक समाज को स्वस्थ बनाएं और अपने परिवार को सशक्त बनाएं। बहुत इम्पॉर्टेंट है ये पहली बार जानना हमें कि हमें स्क्रीनिंग की आवश्यकता है ही क्यों। What is screening that we should know? World Health Organization defines screening as a presumptive identification of unrecognized disease in an apparently healthy asymptomatic population by means of tests, examinations, and other procedures that can be applied rapidly and easily to the target population. In this definition, it is important to understand every word very diligently. By that I mean that these tests are actually applied in a healthy population which are asymptomatic to any disease, and there are tests और examinations which can be applied rapidly, जो तेज़ी से लगाए जा सकते हैं, इनके रिजल्ट जल्दी आते हैं और एक कॉस्ट इफ़ेक्टिव हैं। और ये सिर्फ एक टारगेट पॉपुलेशन में लगाना चाहिए जिन पे लगाने से उस पर्टिकुलर बीमारी के पकड़े जाने की संभावना अधिक होती है। कोई भी टेस्ट हम किसी भी पॉपुलेशन में लगा के उस किसी भी डिसीज़ को स्क्रीन नहीं कर सकते। स्क्रीनिंग को पहली बात समझना बहुत ज़रूरी है। पर अब हमने स्क्रीनिंग को समझ लिया तो हमें ये समझना है कि हमें स्क्रीनिंग करनी ही क्यों है। स्क्रीनिंग करने से हम किसी भी बीमारी को उसकी जड़ से उगने से पहले ही हम उसको डिटेक्ट कर सकते हैं। अगर कैंसर है तो हम उसको अर्ली स्टेज में डिटेक्ट कर सकते हैं। अगर कोई प्री कैंसरस लीजन है तो हम उस प्री कैंसरस लीजन को हम डिटेक्ट कर सकते हैं। दिस इज़ अ कॉस्ट सेविंग strategic investment if we detect cancer in early stage. What are the benefits we reap by detecting any precancerous lesion or a cancerous lesion? If we are detecting a disease in precancerous stage, then we have huge number of treatment options for that particular disease, and then we are actually reducing the resources which will be used for the treatment of particular disease. If the cancer is detected in early stage, then obviously the 5-year survival rates are much better, because the survivals in cancers are stage dependent, and early stage cancers has a 5-year survival rate up to 80 to 90%, as compared to a person who's picked up with a stage 3-4 cancer where 5-year survivals are very dismal, up to 20 to 30%. For individual, it improves the quality of life, it increases 5-year survival, It also reduces the burden on the family, on the economy, because the affected person can be detected early, treated completely, and return back to their normal activities, maybe their household activities or the occupational activities very soon, and hence that person is not a burden on either the family or the society. So now, since we have understood what is screening and why do we require screening, we'll come back to the burden of gynecological malignancies. Yeah.
डॉक्टर अमिता, इससे पहले हम एटलीस्ट मोटे मोटे शब्दों में हम ये जान लें कि बेसिकली स्क्रीनिंग जो है हमें बहुत ही कम पैसा में होता है और रैपिडली, मतलब बहुत जल्द हम उसको अप्लाई कर सकते हैं. इससे बहुत ज़्यादा पीड़ादायक जो टेस्ट बहुत गुजारना पड़ता है पेशेंट को, जो बहुत मेहनत लगता है, बहुत कष्ट होता है, ऐसा कुछ नहीं है. और वो टेस्ट का जो इफेक्टिवनेस, जिसको आप सेंसिटिविटी स्पेसिफिसिटी बोलते हैं, वो बहुत अच्छा है
जी.
और दूसरा सबसे बेटर है कि हम बहुत जल्दी डिटेक्ट करने से, मतलब उसका कम पैसा में, जो सपोज ब्रेस्ट कैंसर अगर होता या सर्वाइकल कैंसर होता तो लाखों में खर्च होता, तो हम कुछ ही हज़ार में ये उसका मतलब कि रोकथाम कर सकते हैं
जी.
और उसका जो सर्वाइवल रेट, नॉर्मली ब्रेस्ट कैंसर अगर सर्वाइवल रेट बहुत ही कम है, तो उसका सर्वाइवल रेट अगर स्क्रीनिंग स्टेज में डिटेक्ट हो और हम उसको ट्रीट करें तो उसका सर्वाइवल रेट बहुत अच्छा होता है
जी. सो डॉक्टर बिप्लब, ये आपने बहुत उचित बात कही कि इकोनॉमिक बर्डन, जिस पे मैंने लास्ट अपने पंक्ति में काफ़ी स्ट्रेस किया कि यदि हम स्क्रीनिंग टेस्ट को और सही स्क्रीनिंग टेस्ट को, पहली बात हम अवेयर हों और हम उसको सही टारगेट पॉपुलेशन पे लगाएं, तो उसके जो रिजल्ट्स हैं वो एक बहुत जल्दी आते हैं. और ये टेस्ट काफ़ी सस्ते होते हैं. वो सस्ते इसलिए भी बनाए जाते हैं कि मेजॉरिटी ऑफ पॉपुलेशन उसको एक्सेप्ट कर सके, उस पर अप्लाई हो, और मोस्ट ऑफ द टाइम्स ये गवर्नमेंट गाइडलाइंस में इनकॉर्पोरेट होते हैं, सो दैट एक सरकारी मशीनरी के थ्रू एक अवेयरनेस, जागरूकता लाई जाए लोगों में और उसकी एक्सेप्टेंस बढ़े.
हाँ जी
जी. सो नाउ कमिंग बैक टू द बर्डन ऑफ गायनेकोलॉजिकल मैलिग्नेंसीज. सो मोस्ट कॉमन कैंसर जो आजकल पूरे संसार में, अब हमारे देश में भी पाया जा रहा है, वो है कैंसर ब्रेस्ट, फॉलोड बाय कैंसर सर्विक्स. आपको ये जानकर प्रसन्नता भी होगी कि जब आज हम स्क्रीनिंग की बात कर रहे हैं तो सर्वाइकल कैंसर हमारे देश में सबसे कॉमन कैंसर हुआ करता था, लेकिन यही सरकारी पद्धतियों के कारण, पॉलिसीज़ एंड गाइडलाइंस के कारण जो अवेयरनेस पैदा की गई सर्वाइकल कैंसर स्क्रीनिंग को लेके, वैक्सीनेशन को लेके, अब यह कैंसर हमारे देश में सेकेंड मोस्ट कॉमन लीडिंग कॉज ऑफ डेथ इन विमेन ड्यू टू कैंसर्स बन गया है, जो कि ये मोस्ट कॉमन हुआ करता था. पर क्योंकि स्क्रीनिंग की अवेयरनेस इतनी बढ़ गई, स्क्रीन एंड ट्रीट मेथडोलॉजी बढ़ गई, स्क्रीन ट्राइज ट्रीट मेथडोलॉजी बढ़ गई, लोगों में एक्सेप्टेंस आई, और अब यह हमारे देश का सेकेंड मोस्ट कॉमन कैंसर इन फीमेल्स, फॉलोड बाय नॉट द लीडिंग कॉज ऑफ डेथ ड्यू टू कैंसर इन विमेन है. और अब ग्लोबली कैंसर ब्रेस्ट हमारे देश में भी सबसे ज़्यादा कॉमन CA ब्रेस्ट हो गया है. यूट्राइन कैंसर, बच्चेदानी का कैंसर, ओवेरियन कैंसर, वल्वल और वेजाइनल कैंसर की संभावना एक के बाद एक कम होती जा रही है. सो सबसे पहले हम ब्रेस्ट कैंसर, जो कि हम सब में मोस्ट कॉमन कैंसर अराउंड द वर्ल्ड एंड अराउंड इन आवर कंट्री भी है, सो इट इज़ accounting for 1 in 4 cancer cases in women. So if you are sitting in an auditorium, you have to realize that 1 in 4 women is going to develop this cancer. So it's quite lethal. And the dangerous thing about this is that it shows no symptoms in early stage, and by the screening techniques, most of the 25% women are picked up in an asymptomatic stage. So that is the importance of screening, because it is an asymptomatic presentation. If we are applying a screening test here, so we are able to pick up those 25% patients who will be otherwise picked up when they are symptomatic and with advanced disease. So just to quote few statistics, 1 in 8 women in India will develop breast cancer over the course of her lifetime. Similarly, in 2022, this figure was 1 in 9 globally. In India, now it has become the common form of cancer for females, leading the cervical cancer. Number of breast cancer which are projected to be by 2025 will be approximately 13% increase in the CA breast, and the district which is leading in the CA breast is Hyderabad of Andhra Pradesh. So this breast cancer is the leading cause of death from cancer in women in India and globally. Every 50 seconds somewhere in the world a woman is dying of breast cancer.
ये बहुत ही ज़्यादा खतरनाक है, बिकॉज हमने सेशन शुरू किया अभी करीब 10 मिनट हो चुके हैं, उसका मतलब हमें 40 औरत अभी तक ब्रेस्ट कैंसर की वजह से मर चुके होंगे,
और ये फैक्ट है।
और ये सेशन खत्म होते होते अराउंड 1 घंटा का सेशन है, 60 मिनट, मतलब 120 वुमेन मतलब कि ब्रेस्ट कैंसर से गुजर चुका होगा। तो ये बहुत दुखददायक स्थिति है। तो इस वजह से हमें मतलब कि स्क्रीनिंग के माध्यम से अर्ली डिटेक्शंस करके उस रोग को मतलब प्रिवेंट करना, उस रोग से मुक्ति पाना एक बहुत ही एक अच्छा उपाय है।
नॉर्मली जो स्क्रीनिंग टेस्ट होते हैं वो अप्लाई भी मोस्ट कॉमन डिसीजेस के लिए किए जाते हैं, और उन डिसीजेस के लिए किए जाते हैं जिनकी संभावना लोगों में सबसे ज़्यादा हो और वो एसिम्प्टोमेटिक स्टेज में ज़्यादा समय तक चलते हों, जैसे कि उस स्टेज में उनको पकड़ने का फ़ायदा हो। अगर हम ओवेरियन कैंसर की बात करें तो वो प्रेजेंट ही 3rd स्टेज में करता है, तो इसीलिए उसके लिए कोई स्क्रीनिंग टेस्ट ही नहीं बना, और उसकी इंसिडेंस भी काफ़ी कम है कि अगर हम उसके लिए कोई स्क्रीनिंग टेस्ट बना भी लें तो भी उसको अगर हम पॉपुलेशन में अप्लाई करेंगे तो कॉस्ट इफेक्टिवनेस नहीं होगा,
बहुत ज़्यादा लोगों को फ़ायदा नहीं होगा, बहुत ज़्यादा कॉस्टली होगा
जी। सो ब्रेस्ट कैंसर में 5 ईयर सर्वाइवल रेट्स जो हैं they are dependent upon the income group of countries. So in high income countries 90% survival rates are seen. They are only 66% in India and 40% in South Africa. So why the survival rates are varying? Why the 5-year survival rates are varying? So these are varying because in high income countries people have awareness about the screening modalities and they accept the screening modalities. So hence when you are detected early, then your survival rates are better. So here is the motto that early detection saves life. So we should be adopting a screening procedure. So what are the key details of breast cancer screening which all of us should be aware of? We should be aware that 25% of diagnosed cases are asymptomatic. Asymptomatic cases have better prognosis. By that I mean if on a clinical examination, I detect a breast lump in a patient, her treatment success and her survival are better when the patient is presenting to me with any of the symptoms. And early stage diagnosis has a better prognosis. So what are the breast cancer symptoms? What we can look for is a lump in the breast, changes in the nipple, or changes in the skin overlying the breast, or a lump in the armpit or in the neck. These are very important symptoms which we should be looking for and we should seek a medical advice. So now coming down to what are the screening modalities which are available. So we have modalities like self breast examination, clinical breast examinations, mammographies, ultrasound and MRI wheresoever is required. So coming down to this point of screening options, self breast examination is not in any guideline, either Indian or global, but it is an awareness raising screening option that every person is the best judge of themselves. So if we examine as an individual our breast according to the laid guidelines, probably we will be the best person to pick up any changes and hence report for clinical breast examination which forms a part of the guideline. So how do we do a self breast examination? So standing in front of the mirror with the hands by the side, by the hands raised up and by the hands on the waist. So this is one of the ways of examining your breast, standing in front of mirror, while lying down in the bed and while taking shower. So these are the 3 positions which we should be aware of, that how we should examine breast self. What are the changes we are looking for? As I've already told, that changes in the nipple, changes in the skin overlying the breast, any lump in the axilla or the armpit, or a lump in the supraclavicular region which we call the neck region. So these are few of the changes, like a thickened area, a dimple, a crusting of the nipple, a red hot area over the breast, a discharge from the nipple, a skin sore, a ulceration, a bump, or a new shape or size which we can see, and which we all of us know most commonly, the orange peel skin appearance. The skin becomes like the peel of an orange, the indurated skin. It is actually a sign of an advanced CA breast. So how do we do it? The procedure I have said, it has to be done at least once a month, and please remember it has to be done after menstrual cycles, because before menstrual cycles the breasts are already engorged, they are under the influence of hormones, and you'll feel lumps in the breast prior to your menstrual periods. So 2 to 3 days after periods, once a month, examine the breast and the armpit, and use your finger pads, not the fingertips. And there are various motions which have been described to examine the breast. One is up and down movement, the wedge-like movement starting from the nipple to the periphery, circling around the nipple, examining the nipple, doing a gentle pressure with bimanual hands on the nipple to check for any abnormal discharges. So these are the ways to do the examination. So after a self-breast examination done every month, if I do notice anything, I have to report immediately. Otherwise, this is the laid down guideline how to do a clinical breast examination for the physicians. Similarly, as in the self-breast examination, starts with inspection followed by palpation in the 3 manners which I have already explained, and then checking for consistency, mass, tenderness, pain, any nipple discharge, and armpit or a supraclavicular lymph node. So what are we looking for in an armpit or a supraclavicular region above the neck bone, I'll say? So we are looking for a enlarged lymph node which might have a deposit of cancer of the breast. Then this modality is mammograph. It is like taking an X-ray of the breast, and the breast is compressed between the 2 plates, and the image is taken, and then it shows up like a X-ray film to the radiologist. So in Indian specific context, again, we are a resource constrained country. So we, as a gynecologist and a gynae oncologist, we are actually following a opportunistic screening. When a patient comes to us as a doctor for XYZ problem, we always request patient to get a breast examination done. We, during examination, make the patient aware of the self-breast examination procedure. We also tell them to go online and have a look at all the possible ways she can examine her breast. According to the NPCDS, clinical breast examination every 5 years for women more than 30 years should be performed by a frontline worker, which can be ASHA or an ANM. So the global guideline is to perform mammography starting from the age of 40 years till 74 every 1 to 2 years depending upon the resources. In India, we do follow clinical breast examination more than 30 years and upgrade to mammography or ultrasound according to the findings. A woman who is less than 40 years is ideally advised to go ultrasound of the breast because of the increased density of the breast. A high-risk woman, by high risk I mean that a woman who has got a BRCA mutation in herself or has got a family history of CA breast or CA ovary or has a history of prior chest irradiation needs an annual MRI and a mammogram irrespective of the resource setting. So WHO again recommends according to the resource setting. In high-risk women, we do an enhanced screening protocol. We can offer them chemoprophylaxis or a risk-reducing surgery according to the findings in the screening. So now coming down to the second most cancer in the women, it is cervical cancer. And what is cervical cancer to understand?
लेकिन डॉक्टर अमिता, इसमें आपने जो पहले बताया कि अभी सर्वाइकल कैंसर का रेट बहुत इंक्रीज हो गया है बिकॉज ऑफ द स्क्रीनिंग.
The rate has reduced because of the screening.
Okay.
So the thing is, the cervical cancer used to be the most common cancer in the women. It used to be the highest cause of mortality due to cancer in women in India.
Okay.
But because of the awareness of the screening and the incorporation of screening guidelines by the government of India, and incorporation of HPV vaccination, the incidence has come down. So
that is a great news.
Yeah. So that is the importance of screening. So it is now the second most common cause. So breast cancer used to be second, now it is the leading cause. So
Okay.
now the aim is to increase the awareness about carcinoma breast.
Okay.
So now we'll be coming down to cervical cancer. So what is cervical cancer? So actually cervix in a layman's language is known as the mouth of the uterus. So mouth of the uterus, when there is an uncontrolled tumor growth, then it leads to cervical cancer. But then the good news is that it gives us a huge latent period amounting to 10 to 15 years from a pre-cancerous lesion to a cancerous lesion. So yes, we do have a screening protocol which is enforced by the government of India, and then the vaccination protocol. So all of this is affecting and reducing the incidence and mortality of this particular cancer.
तो उसमें सबसे इम्पोर्टेंट बात यह है कि जो सर्वाइकल कैंसर प्री कैंसरस से कैंसर बनने में 10 से 15 साल तक का जो टाइम है वो एक बहुत ही एक गोल्डन अपॉर्चुनिटी है. और मेरे ख्याल से आप आगे बताएंगे कि हमें किस एज में ये टारगेट करना चाहिए और कितना फ्रीक्वेंटली डॉक्टर से सलाह करना चाहिए.
फॉर श्योर. सो वी हैव टू नो दैट कैंसर ऑफ द सर्विक्स can affect any woman, and the most common risk factor is sexual promiscuity. It is a sexually transmitted disease. So utilizing barrier contraception is the most important preventive measure to prevent happening of cancer cervix, and then followed by HPV vaccination, because HPV is human papilloma virus. It is actually associated with 99% of cancers of cervix. If we are vaccinating against HPV high risk viruses and promoting a barrier contraception, having a single sexual partner, and avoiding cigarette smoking, which reduces our immunity, and avoiding any such chronic infection of the cervix, then we are very much protected against this preventable cancer. So this is known as only vaccine preventable cancer. So we should know that this is almost 99% preventable. And how we can prevent, I'll be just detailing upon. So almost 75,000 women are dying due to cancer of the cervix in India. And now it is second most common, which I have been always stressing upon. And to note is that 90% of women who have cervical cancer did not have regular screening. So it can happen in women who have been regularly screened, but then they are picked up early, they are treated early, and their survivals are better. But to note is that in the cervical cancer patients, when we have seen them retrospectively, 90% of women have not even had a single screening in their lifetime. So cancer of the cervix is preventable and it is treatable if picked up in the early stages. Why? Because it gives us a long latent period and there is a vaccine with which we can prevent it. The only thing is that we have to be aware and follow the screening protocol. So again, coming back to the cause of cervical cancer, 99% of the cervical cancers are HPV dependent, and which is the most common virus transmitted through sexual contact. Not all HPV infections will lead to cancer cervix. A persistent HPV infection will cause the local cervical changes in the cells, and the persistence of these infection will lead ultimately to cervical cancer. So HPV vaccines are a critical primary prevention method against cervical cancer. They are very safe and provide strong protection against cancer causing HPV types. So HPV virus is of hundreds of types. But there are high risk HPV which actually lead to cancer, and we have to screen for those high risk HPV cancers and vaccinate against those high risk HPV. So by now we are very much aware that cervical cancer is an almost completely preventable disease. Behavioral modification, vaccination, and adopting screening modalities can almost completely prevent this disease. So since it's a completely preventable disease, there is a global strategy by WHO that we should try and bring down the incidence of cancer from this 16 per 100,000 women to 4 per 100,000 women and reduce the mortality caused by this cancer. So how is WHO planning to achieve this strategy? The goal is 90-70-90. By that we mean that we have to vaccinate the target population. 90% target population should be vaccinated, and the target population which can be vaccinated is actually girls up to 15 years of age who are sexually naive. Then 70% of the women in the target group should have adopted screening protocols, and the women in this target group are the women up to the age of 45 years who should be aware of the screening protocols and should adhere to the screening protocols as made by the government. Then the other 90% strategy is providing the treatment modalities and the palliative treatment help to the patients who are diagnosed with CA cervix. So by adopting this 90-70-90 policy of WHO, we will be able to reduce the mortality of the deadly cancer to less than 4 per 100,000 women, and thus reducing it as a global cause of death. And the target which has been set by WHO is by 2030 we should achieve this. So now talking about all this, that how to reduce and what to follow, we should know what type of screening test or the modalities are available for screening of CA cervix. So most commonly available at grassroots level is something called VIA, which is visual inspection with acetic acid of the CA cervix, followed by a cytology test which is known as a pap smear test, which can be either done by conventional cytology or a liquid based cytology. There are different ways of doing pap smear test, the conventional being cheaper, widely available, and the liquid based cytology being not so widely available, costly, but there are advantages that we can do HPV DNA testing over a liquid based cytology. We can also do testing for other sexually transmitted diseases, and it has got a better sensitivity over the routine conventional pap smear. Then there are other methods like HPV DNA testing, like colposcopy, and there are a few more. So which modality should we follow? So, and when to start our self-testing? So the global guideline says that the screening should start by the age of 21 years, and for 21 to 29 years, pap smear should be done every 3 years, and for 30 to 65 years, if we are doing a pap smear test, it should be done 3 yearly. If we are doing it with HPV testing, it can be done once in 5 years. Now even the guidelines say that if the resources allow, then HPV testing can be alone done as a primary modality of screening every 5 years. If more than 65 years, we can stop screening if previous 3 tests are negative, or the patient has had a hysterectomy due to benign reasons, or if she has been never screened and we do a pap smear test now, and if it is negative, then we can just stop the screening at the age of 65 years. But again, coming to the Indian context, we are again a resource constrained country. So we offer a visual inspection with acetic acid every 5 years for women more than 30 years. And yes, we do offer pap smear and HPV depending upon the available resources. Sitting in places like Delhi and Gurugram, we do offer pap smear, that too with the liquid based cytology as the first modality, and if the patient can afford the HPV DNA testing. But yes, when you are going to the grassroots levels, these ASHA workers, A&M, where not much of expertise is required to assess or interpret the test, a visual inspection of acetic acid is the treatment modality which provides us with immediate results. So in a country like us, we should start screening for CA cervix at least by the 25th birthday of the woman, and if not possible, at least by the age of 30 years is a must. So This is how a pap smear kit looks like, and there is a liquid based cytology and there is a conventional test, and there are pros and cons of both. But yes, there are ways of doing pap smear cytology. Patient has to be directed to do certain things and not to do certain things prior to getting tested, but it is a very simple test. And what do we expect during a pap smear testing? There is a speculum which separates the vaginal wall. There is a swab which is inserted into the vagina, and then it collects the cells from the cervix, and then the cells which are collected are centrifuged, and the samples are sent to the pathology lab for examination under the microscope. This is a clinical setting where the patient undergoes a gynecological examination, and this is the position of the doctor and the patient, and believe me, it's a totally painless procedure of primary screening. Now, with advancement, we do have cervical cancer self-collection, and it's as easy as the procedure which is shown 1, 2, 3 step. You have to just take out this swab, insert the swab into the vagina, rotate for 30 seconds, place the swab back, and return to the healthcare provider. And when we are doing this test over this pap smear, we can even add HPV DNA because this is a liquid based cytology. So no need to go to the clinician, just learn the ways to do it and increase the self cervical screening. So what do we look when we are getting a slide of the cervical smear testing? So we are looking for any abnormal cells or normal cells. So coming down to the grassroots level, so the pap smear test, if not available at the ASHA A&M level, so we are doing something called visual inspection of the cervix with acetic acid. Then again the position remains the same as in the pap smear testing, and there is an application of freshly prepared acetic acid on the cervix and the examination of the cervix by the health worker. Any abnormal areas which turn white after application of this acetic acid denote some abnormality, and we can either take a biopsy there, or the healthcare worker is not tuned to that, they can just refer the patient to a healthcare facility. So what are the common reports seen? They are reported as normal. By normal we mean negative for intraepithelial lesion or malignancy, negative for HPV, or via negative. So if this is the report, then patient can follow a regular screening guideline, which is a 3-yearly pap smear test or a 5-yearly co-testing or a 5-yearly HPV DNA testing. If there are new symptoms in between this screening interval, they have to be reported immediately. But if the common report is inflammation, like it will look like this, then we have to give some antibiotic cover, see the patient again, and treat accordingly. Otherwise, we can see an atypical cell, a cervical intraepithelial lesion, low-grade squamous intraepithelial lesion, carcinoma, a high-risk HPV positive, or a VIA positive or a suspected cancer. So all these reports need to be referred to a gynecologist who can further advise management and follow up accordingly. So at 65 years, if there are 3 consecutive negative cytologies, 2 consecutive negative HPV tests, or if she has never been screened once, test negative, we can just stop pap smear screening anymore. And post hysterectomy, if the patient and the history for hysterectomy is not because of any cancer or a precancerous lesion, we can just stop doing sampling. So again, just reinforcing, pap smear cytology to be done every 3 years, HPV testing to be done every 5 years, visual inspection with acetic acid to be done every 3 to 5 years. So there's a very common question, do I need a cervical biopsy? So you don't have to worry about do you actually need a cervical biopsy, because if the doctor is finding something abnormal on your pap smear, she will advise you an upgradation of an investigation which is called colposcopy, and she will do a examination of the cervix under magnification. So in the pap smear or a routine gynecological examination, the cervix is examined with naked eye, but during colposcopy the examination is done under magnification, which can range from 5 to 7 to 12 times, and we apply certain chemicals like Lugol's iodine or again an acetic acid and look for the changes which occur on the cervix any abnormal vascularities which we see, and then we take targeted biopsies. Only if we find these abnormal things, we take a targeted biopsy. But in an obvious growth, there is no need of colposcopy. We can just take a biopsy of the growth. So going further, on the reports which are available after screening, the further screening intervals will depend. If it's a normal report, then obviously the normal protocol. If it has been an infection, a reassessment after 3 months. If it is a pre-invasive lesion, then the protocol is 3 monthly to 6 monthly depending upon the grade of the lesion. If it is cancer, then obviously the treatment changes. So we also see whether it is whether our clinical findings, cytological findings, and the pathological findings are correlating or not. If they are not correlating, then we will require some excisional procedure on the cervix, and if they are correlating, we might do some ablative procedure and treat the particular grade of lesion. So what happens if somebody is detected with frank cervical cancer? The options are a surgery, radiotherapy, chemotherapy, targeted therapy. So just remember, in any cancer, if surgery can be offered, that means that it is not an advanced cancer, it's a localized cancer, and the survival rates are better, the prognosis is better if the surgery can be done. If surgery cannot be done, that means that either the disease is locally advanced or it has become systemic, and then the patient will either require radiotherapy or chemotherapy or a combination of both, and the patient might require plus minus any targeted therapy. So we have to take time to review the options, in what stage we are. If we are not understanding the treatment we are undergoing, we can always discuss with the clinician. If we are not sure, we can always ask questions. So this is just a basic comparison between the screening protocols in both most common malignancies which we are dealing in women in our country and globally. So primary screening tool remains mammography, which is a gold standard in all economic settings in breast cancer. But in restrained countries like us, we are doing a clinical breast examination and upgrading according to our findings. For cervical cancer, the pap smear remains the gold standard, followed by HPV DNA, and VIA remains gold standard at the rural or the community level. So Indian guidelines I have highlighted separately so that all of us have to remember that clinical breast examination is a must every 5 years for women more than 30 years, and VIA every 5 years for women more than 30 years for cervical cancer. In high-risk population, we need changes in the screening protocols according to the family history, according to the mutations in the family, according to the HIV status in CA cervix, according to the immunity. The frequency increases and the treatment modalities change. So feasibility in low middle income countries, limited mammography, so we rely on clinical breast examination, and with VIA it is feasible to do screen and treat protocol of the FOXI and of various guidelines of the country. So public health, what is the public health impact of screening? So most common cancer in Indian women is now the breast cancer, and a late stage detection is very common. So when we are detecting it late, we are reducing the 5-year survival, and we are increasing the economic burden on the family, on the person, and we are on the country as well. And CA cervix remains the leading cause of cancer deaths, and it is preventable with HPV vaccination and screening. So a word about vaccinations which are available for cancer cervix. So we know that around 50,000 lives can be saved if we are vaccinating girls between the age of 9 and 14. So if all Indian girls were vaccinated between the ages of 9 and 14.
Yeah, this 50,000 is Indian context, not the global context.
No. So this is for Indian context. These all studies have been done because now we have made our own vaccine. Yeah, so all the data has been collected and published, because we have now we have our own vaccine.
Yeah, all these vaccines are having very good efficacy at the population level.
Yes, they are having very good. So presently we are not having the data regarding the Indian vaccine because it is new. But yes, since the vaccine is targeting the 4 most common high-risk HPV variants of the HPV, which are 6, 11, 16 and 18. So 6, 11 are known to cause the warts, and 16 and 18 are known to cause approximately 99% of cancer of the cervix or anogenital or oral. So when we are giving HPV vaccination, we are in fact protecting the individual not only from CS cervix, we are protecting them from anal cancer, we are protecting them from oral cancer. So that is why the guidelines are coming up to vaccinate even the boys of the age. Yeah. So by vaccinating our daughters before their 15th birthday, we can protect them from developing cancer of the cervix. So these are the vaccine options which are available. I think Cervarix is out of market now. It used to protect against 16 and 18. Now we have Gardasil vaccine, Gardasil 9 and Cervavac, which is made by Serum Institute of India, and it's an Indian vaccine. So Gardasil 9 is protecting against the 9 high-risk HPV viruses, and Gardasil and Cervavac are protecting against 4 high-risk HPV viruses. So what is the ideal time for vaccination? It is actually before the child becomes sexually active. So basically in a sexually naive person, and the target age is 9 to 14 years. Then it can be extended till 45 years, but it's a partial prevention because the exposure to the HPV might have happened and the protection is reduced to the already infected person. Then there is a guideline to protect, to give the HPV vaccination for HPV boys of the age of 19 to 26. So the boys can also be vaccinated.
Yeah, I think this is the very important point to know all this, that it is not about the vaccine is for these girls, but for boys also, because this human papilloma virus is also causing some kind of cancer among the boys. So we have to be very sure, and these vaccines are not very costly also.
No, not
so
at all.
You can plan, and if you have these eligible girls at home, particularly 9 years to 14 years of age, the effectiveness is very good. Otherwise, as Dr. Amita says, the amount of the efficacy of the virus, this vaccine is less because they already have a exposure. So बाद में आप ये नहीं कह सकते कि हमने तो वैक्सीन भी लगाया था फिर भी कैंसर हुआ. And it is because they may get vaccines at the later age.
Yeah. So the right age to get it when they are sexually naive, and the dose is actually 2 doses. For the girls who are less than 14 years of age, it is 9 to 14 years. And beyond that age group, the number of doses also increases and the efficacy also decreases. Similarly, a very important point which has been told by Dr. Biplab, that we have to give boys also the vaccine, and the age group remains same, the dosing schedule also remains same. Why to stress upon the boys is, it is a sexually transmitted disease. If both the boys and the girls are vaccinated, the chances of a HPV associated cancer will be actually minimal.
Yeah. So Dr. Amita, you can enlarge this slide, full view. Yeah, I think this is better.
Okay. So what happens if you miss a dose? Take remaining doses as in the schedule. If you have taken 1 dose, we can just take the other dose at any time. So earlier there used to be confusion regarding repeating the schedule. Now there is no confusion. If you have taken 1 dose, you can take the other dose at any time. Then if same vaccine is not available, suppose I have taken Gardasil 1 dose, and now I am not able to procure Gardasil due to XYZ reason. I have changed my state, I have changed my country, then I can take the Cervavac vaccine. It is fine. The it is both, all the vaccines are protecting against the same high risk HPV virus. So we should not be either stressed about missing a dose or changing the product. We can take any brand. So in pregnancy, yes, it is not recommended. And if we have already taken the HPV vaccine and then we realize that yes, the patient is pregnant, then, or sorry, not the patient, the person is pregnant, there is no need of medical termination. She can continue her pregnancy without fear of any teratogenicity in the fetus, and she can take the next dose after the delivery. Can we take it during lactation? Yes, it can be given during lactation. No excretion of the virus or the vaccine has been seen in the breast milk. So if the person is already taking some other vaccine, can they take these vaccines concomitantly? Yes, these vaccines can be taken concomitantly, and there is no cross reaction between the two vaccines. But a positive screening test, if the patient has got a positive screening test, by a positive screening test I mean if patient has a LSIL, low grade intraepithelial lesion, or a high grade intraepithelial lesion, can I take the vaccine as a treatment for these lesions? The answer is no. This is a preventable vaccine. A cancer, a lesion which has already occurred due to HPV cannot be treated by the vaccine. So it is a preventive measure, not a treatment modality. So what happens to the screening protocol after I am HPV vaccinated? Do you think that if you are HPV vaccinated, there is no need to follow the screening protocol? The answer is no. You have to follow the regular screening protocol in spite of being fully vaccinated against the high-risk HPV vaccine. Because point to remember is it is 99% HPV dependent. But what about the 1%? And we are not detecting all the high-risk HPVs by the tests available. Sometimes we are detecting only 16 and 18, sometimes we are detecting only 16, 18, 31, 33. So all the 13 to 15 types of HPV may not be detected by the particular tests which we are doing. Hence, screening should not be replaced by vaccination. Anybody who is fully vaccinated for HPV should still follow the screening protocol. So screening has to be continued.
And moreover, vaccine never give 100% protections. Yes. Also. So
yes.
In spite of taking the full dose vaccines as per the recommended way, still a person is having a small percentage can develop the yes. cervical cancer. I think this is the reason a person should take the screening test irrespective of the whether they are taken these vaccines or not.
Yes. So
yeah, we can tell more about this screening and HPV.
So yes, so few points about the other cancers like the uterine cancer and the ovarian cancer. They are the third and the fourth leading cause of malignancies and associated mortality in the women. So uterine cancer, there is no validated screening protocol. Everybody should be aware of this. If somebody has a scare of uterine cancer and says that please regularly screen me for uterine cancer, so there is no screening modality which has a sensitivity and specificity to the tune that we can detect it early. But yes, there are advantages of screening in high risk females. So by high risk, what we mean, in again the patients who have got MMR gene deficiency, or who are a part of something called Lynch syndrome, who have got a significant family history of the cancers of the uterine, breast, prostate, pancreatic cancers. They are running in these families. We can offer them these screening modalities. So what are the screening modalities for endometrial cancer in high risk women? One is the ultrasound, which is first step is to do a transvaginal scanning and an endometrial aspirations. So combination of transvaginal sonography and endometrial aspirate has a negative predictive value of 96%. So if both the tests are normal, then the patient developing that cancer is very low because the test has got a very high negative predictive value. So when to perform hysteroscopy. So if the TVS is suggesting a focal lesion, a polyp, then an endometrial aspirate has the chances of missing that focal lesion. Then it will be a negative endometrial aspirate, but still there is a focal lesion. Similarly, if a patient has got a negative report on endometrial aspirate but is persisting with the symptoms of irregular or a postmenopausal bleed, then still there is an indication of hysteroscopy. Similarly, if the reports of the endometrial aspirate says that it has got an inadequate cellularity or the tissue is inadequate to comment, then we need to undergo the patient with hysteroscopy DNC. And again, in hysteroscopy, the specificity is up to 99.7%. By that we mean if the after hysteroscopy, the doctor says that they cannot see a lesion and the random 4-wall biopsy also gives a negative report, the patient developing a cancer or having a cancer at present is very, very low, since the specificity is to the tune of 99.7%. A word about ovarian cancer, because the ovarian and breast cancer are actually running in the families because of a common gene mutation with the patients carry in both, which is called BRCA mutation, which is a BRCA mutation. If the patient is carrying, then there are protocols for breast cancer screening, which I have already detailed upon the high risk mutations, and then the ovarian cancer screening has to be followed in women with BRCA mutations, and in only those patients who are high risk, the incidence and stage of the detected cancer is affected by these screening protocols. Otherwise, a routine ultrasound, a CA125 testing or any other testing does not increase the pickup of the cancer or the survival if the patient has cancer later on in the life is not affected by any of the screening modalities. So there are no screening modalities for detection of carcinoma ovary in general population. In patients with high risk, we have certain modalities, but not in an average risk population. So coming down to the conclusion that screening for cancer is actually self-love in action. If I am aware of screening modalities, if I am available and adhering to the guidelines which are laid down and I am following a screening protocol, I am living a healthy life and I am working to my fullest, and Sashakt Nari, Sashakt Parivar is that which follows. If I am healthy, I am cancer free.
Yeah, I think most important thing here is like हम में से बहुत सारे लोग अपनी गाड़ी को तो सर्विस पे रेगुलरली बेचते हैं, ये सोच के कि गाड़ी चलते हुए बीच रास्ते में कहीं रुक ना जाए, लेकिन हम अपनी खुद के शरीर का हम रेगुलरली उस हिसाब से सर्विस नहीं कराते, या फिर जैसे कि हम हमेशा सोचते हैं कि गाड़ी में तेल एडिक्वेट होना चाहिए क्योंकि चलते हुए रुक ना जाए, हाँ, लेकिन हम अपना उस टाइप का कोई प्रिवेंटिव मेजर्स हम प्रॉपरली नहीं लेते, ये हमारा एक बहुत बड़ा लापरवाही है. तो मेरे ख्याल से अगर एवरी वुमेन is aware about this kind of screening test availability, जो कि बहुत इजीली हो सकता है, बहुत पैसा भी नहीं लगता है और इससे आपका बहुत ज़्यादा फ़ायदा होगा, सिर्फ आपको नहीं पूरा परिवार को. तो मेरे ख्याल से सब नारी को ये चीज़ अपनाना चाहिए. लेकिन मैं इसमें ये बात ज़रूर बोलूँगा क्योंकि हमारे समाज में नर और नारी जो होता है एक दूसरे को कॉम्प्लीमेंट करते हैं. नॉर्मली ये ऑपोजिट नहीं है, दे आर कॉम्प्लीमेंटिंग ईच अदर. तो नारी का सशक्तिकरण तभी वो सार्थक होगा और संपूर्ण होगा जब उसका जो नर है, जो उसका घर का जो आदमी है, वो भी उसको जाने और उसको एनकरेज करे कि ये चीज़ से मेरे परिवार में और भी सुख समृद्धि आ सकता है, मेरे परिवार का सफरिंग कम हो सकता है. तो इसीलिए ये जो प्रोग्राम है आज का सिर्फ वुमेन सेंट्रिक नहीं है, दिस इज़ फॉर बोथ मैन एंड वुमेन इक्वली. Because if anyone in the family is suffering, then entire family will be suffering. So हमें कोई भी चीज़ शुरू होने से पहले डिटेक्ट करना, जैसे डॉक्टर अमिता ने बताया कि हमें स्क्रीनिंग की माध्यम से प्रिवेंट करना है पहला स्टेज में, पूरा बीमारी होने से पहले. तो इसे ही वैक्सीन मेथड्स भी है जिससे हम बहुत सारा जो सर्वाइकल कैंसर है उसको प्रिवेंट कर सकते हैं। तो हमें बहुत सारे चीज़ जानना है। तो डॉक्टर अमिता, एट द एंड आप कोई स्पेसिफिक चीज़ बोलना चाहेंगे हमारे दर्शक को?
तो मैं ये कहना चाहूँगी कि सर्वाइकल कैंसर के बारे में तो हमारे देश में जागरूकता काफ़ी बढ़ चुकी है, उसकी वैक्सीन को लेके जागरूकता काफ़ी बढ़ी है। बट इस चीज़ को भी हमें मानना होगा कि वैक्सीन को लेके जागरूकता के साथ लोगों में वैक्सीन को लेके डर भी बहुत पैदा हो गया है। बहुत सारे देशों ने वैक्सीनेशन को अपनाने से मना कर दिया है कि वैक्सीन के कारण काफ़ी डेथ्स हो रही हैं या न्यूरोलॉजिकल डेफिशिएंसीज हो रही हैं। मैं आपको ये बताना चाहूँगी कि ये एक मिथ है। वैक्सीन से रिलेटेड, स्पेशली सर्वाइकल कैंसर वैक्सीन से रिलेटेड एक भी डेथ स्टैटिस्टिक्स में ग्लोबली रिपोर्टेड नहीं है। कोई भी पेशेंट को इमीडिएट इफ़ेक्ट ऑफ इंजेक्शन के कारण से, यदि कोई सिंकोपल अटैक जिसको हम कहते हैं, कोई घबराहट या लॉस ऑफ कॉन्शियसनेस ऐसा कुछ हो गया हो, तो वो किसी भी इंजेक्शन को हम उस चीज़ के लिए दोषी ठहरा सकते हैं। लेकिन सर्वाइकल कैंसर की वैक्सीन को इस चीज़ के लिए दोषी ठहराना उचित नहीं रहेगा। तो सर्वाइकल कैंसर की वैक्सीन सरकार कोशिश कर रही है देश में बनाने की, उसको उपलब्ध करवाने की, उसका प्राइस इतना कम करने की कि वो आम जनता उसको अफोर्ड कर सके। धीरे धीरे उसको हम ये कोशिश करके जो हमारा इम्यूनाइजेशन शेड्यूल है हम उसमें भी लाएंगे, ये सरकार की कोशिश है। तो हमें अपनी समझ से और अवेयर होके आगे बढ़ के वैक्सीनेशन को लेना चाहिए, क्योंकि अंततः मैं बताना चाहूँगी सारे कैंसरों में सिर्फ सर्वाइकल कैंसर ही एक वैक्सीन प्रिवेंटेबल कैंसर है। तो ये संदेश हमें बिल्कुल क्लियर होना चाहिए।
थैंक यू वेरी मच डॉक्टर अमिता, आप इतने दूर से आए और हमारे स्टूडियो में आके इतने सारे जो इम्पोर्टेंट जानकारी हमारे दर्शकों को दिए, तो इसके लिए हम पूरे इग्नू परिवार से आपको बहुत बहुत आभार। तो हम यहाँ पे थैंक्स बोलना चाहेंगे कि हमारा एंटायर टीम ऑफ EMPC जो हमें ये प्रोग्राम ब्रॉडकास्ट करने में मदद कर रहा है। और मैं चाहूँगा कि आप सब लोग हमेशा स्वस्थ रहे, अच्छा रहे, पूरा परिवार खुशी से संपन्न रहे। यही दुआ के साथ हम ये प्रोग्राम ख़त्म करते हैं। थैंक यू वेरी मच। नमस्कार।
धन्यवाद।